Before I dive into my presentation, I want to take the opportunity to thank the Health Economics Unit and Stanley in particular for inviting us to be part of this excellent health financing conference, and as well to the government and people of Antigua and Barbuda for being such excellent hosts. And in particular, Minister, it's very refreshing, very invigorating to hear a politician talk with so much exuberance and commitment to the health sector and to do the right thing. I got my marching orders already from Stanley, so I will run or sprint through this particular course, looking a little bit in terms of the background of the National Health Insurance, present the geographic and population coverage, and so on. So, and do that in 20 minutes. 20 minutes, right? 22? All right. In this slide, basically don't pay attention to the details of the slide, because the point I wanted to make with this slide is that we initially started the whole process of the discussion on national health insurance as part of the overall health sector reform process. And when we're talking about health financing, that is a component of the whole health reform process, where we're looking at the model of care, the governance structure, and how to finance that model of care. And pay attention that we started in 2001, and we're still struggling to move forward. The message is, this is not an overnight thing that you are going to achieve. This is a long process. I consider this to be an ultramarathon, where you need to pace yourself. You need to understand that you will have a lot of challenges. You will have to make modifications as you go along. Learn from mistakes. You will be making mistakes. But you need to continue the struggle. You need to ensure that you have that long resistance to move on. Basically, on average, every 5 years, we've been able to move the coverage a bit further until COVID came along as well, and that certainly made us lose a couple of years. However, I believe we're almost back on track in what we want to do. Where are we in terms of coverage with the national health insurance and the healthcare model that we're promoting? We're in the north. You can make the association with the map on the side. On the north, we have basically 1, 2, 3, 4 polyclinics that we contract. One recently, and basically they're public Ministry of Health facilities that we contract to provide specific package of services. But in this last year, one of these was leased out by government to a private entity for them to provide services. So the human and basically because the human resource exists in the private sector. So this is an experiment where we used a healthcare facility from the government and contracted a private entity to provide services. By the way, what we're paying the private entity is less than what we were paying the government entity. We pay on a per member per month basis. In the south side of Belize, where we started the project, we were talking last night that it was initially a 6-month pilot project, and it extended to almost 3-4 years pilot project. We have a combination of public providers, private providers, and NGO. In the south, we cover basically public providers. We contract with public providers. We have in Stan Creek District, we have 2, and in Toledo District, we have another 2. The total population coverage at this point in time is about 150,000, which is about only 33% of the population. That doesn't mean that the rest of the population doesn't have access to care, but it's a different model of care. It's within the government facilities. What I'm talking about is in terms of contracting facilities to provide specific services and being monitored and held accountable for what we have contracted. In terms of, well, it's being financed right now, and I just showed from 2008 to the present date through government general revenue. So government transfers the funds over to the National Health Insurance, and then we issue out the contracts. Our administrative expenditure, I did not put the percentages there, but the administrative expenditure, 95% of our expense goes to paying the providers. And our administrative expense varies between 5 to 7%. All right. In this last year's budget, 2022 to 23, we received a significant increase in our budget. And we were, together with the Ministry of Health, we were one of those units that did not suffer the huge impact in cut in terms of resources that other ministries suffered. So yes, there were cuts, but they were not to the extent as what happened with the other. And that part of it was because COVID came to underscore the importance of the health sector, which is I think one of the big, I wouldn't want to say benefits. If you want to look at the bright side of the pandemic, it highlighted the importance of the health sector in development. Now, I'm just very quickly going through this slide to show you what was offered before COVID, what adjustments we made during COVID, because we had to slightly cut down on some of the services, and what we're doing right now. So in the yellow section illustrates what we were offering pre-COVID, basically contracting, buying outpatient primary care services. With all the support services, we have contracts with certain pharmacies. We got into the business of also tendering and procuring pharmaceuticals. That allowed us to save a significant amount of money because the tender prices that we got, and we didn't tender for everything. By the way, we selected the 37 priority medications, which included those required by protocol to treat the hypertension and diabetes, which is one of the big problems in Belize, and some antibiotics in there. But there are 37 medications that we distribute to approved pharmacies that we have contract with. We pay them a dispensing fee, and then they issue the prescriptions based on patient referrals, medical referrals. So that was pre-COVID. During the COVID, and the other thing that's important to note is that we have a slightly different payment mechanism with private providers and public providers. With private clinics, we pay per member per month, strictly for outpatient services. And then we have different contracts with pharmaceuticals and support services. With the public facilities, because government subsidizes the medications and all the other support services, labs and imaging services, we only add to the capitation a slight amount to allow the facility, in case they run out of any medication or they have some reagent that they need to purchase, then they have some resources to do and procure it. Because with public entity, you have you go through cycles where you run out of medications, there's no reagent, expired reagents. You have that problem that usually does not exist in the private sector. So we only, we pay the public entities the per member per month plus a small increase in case they run out of medications to be able to buy it. During the COVID pandemic, we had to take that out. So that was one part of what we cut out from the public entities. We cut out some of the services like deliveries at hospitals that we used to cover. And that allowed us to reduce our expenditure based on the budget that we were given, but did not affect as much the access to care for the population in the areas we covered. Now that we're recovering, what we have done now is, especially with public entities, is that instead of adding back the per member per month for the support services, we have now decided to distribute pharmaceuticals for the same 37 medications that we purchased to distribute to public facilities. Why? During the pandemic, the government basically ran out of all medications to treat diabetics and hypertensives. There was no lab reagents to do the basic tests to monitor these patients at HbA1c, basic glucose. There was a lot of COVID testing, but all the other items were disappeared. I mean, it was hard to get. They ran out of it. So what we did now is we now procure the medication and distribute it to public entities, and we have contracted private labs to provide the panel of services focusing specifically on chronic non-communicable diseases. So those were additional, and as I said, we took one of the facilities that was a government public facility and leased it to a private entity to provide services in a rural setting. Okay. Interestingly enough, in November of 2020, we had an election and there was a complete change in government. I have taken this directly from their political manifesto. We were fortunate enough that when election was coming up, we were invited to present what we consider to be the vision and the future and the development of the National Health Insurance Scheme. And that was included in the manifesto. So when government came in, it was very clear in the manifesto that the National Health Insurance would be one of the priority pillars for the health sector. That there would be work to improve the governance structure of the whole health sector. We talked there about separation of functions, but it's basically to address the whole organizational structure of the health sector and improve the leadership and governance there. So politically, we had the stage set, we had the mandate, we had the support, and so it was just a matter now of, it was just a matter now of delivering. So we already had worked on some of the proposals for the expansion of the National Health Insurance in terms of costing, the different packages, and submitting to government different options to move forward. And the result, we had the support of the Pan American Health Organization, who we got a consultant to come down and do the packages, do the costing. We did a fiscal space analysis to see where we would be able to get the sustainable source of financing, because what I forgot to mention in the beginning, the only thing that was really holding us back is a policy decision on where we would get that sustainable source of financing to be able to implement it countrywide. Okay? So I'll very quickly just show you the different packages that we had. A basic P1, what we call a P1, primary care 1, primary care 2, and comprehensive and bold. The basic package is what we're offering in essence right now, and then the others were add-ons to that package. Just so that you look at the details of each one of them, those are the services that are included under a P1 package. Most of it is being provided at this right now. I believe only contraceptives we're not providing, but that's one of the things that we want to include. The P2 package are, in addition to the P1, those are additional services that would be contracted for. And then the P3, which is a more complete package of services. All right, and as I said, the manifesto of the new government was that we should now move to the implementation of a rollout for the national health insurance countrywide. So what we did is we, through the Pan American Health Organization, did a review of the fiscal space. I'm almost at my last slide. We did a revision of the fiscal space analysis because COVID did mess up the whole economy, so we had to update the information. We're looking at other proposed sources of financing. Taxes is one of those that we're looking at. And then increasing Social Security contributions to health. One of the things I've heard is a lot of the medical benefit schemes do invest a lot in health. In Belize, we feel that they need to take on a little bit more responsibility for healthcare. So that's going to be a fight down the line. The unfinished reform agenda, we have a steering committee established already, led by the Minister of Health, and Deputy Chair or Executive Director, Dr. Marco Mendez, that will be looking at how we restructure the health sector to improve governance and leadership, and ensuring that essential public health functions are kept in the fore. And then, well, since I told you we got an increase in our budget, we also now need to this. And we have already done our groundwork, and we already have the plans on how to do that. Hopefully, by January next year, we should be expanding to another area. So maybe at the next time when we come, instead of 33% of the population, we'll be closer to 50%. I couldn't finish my presentation without sharing our the vision of the National Health Insurance and Strategic Plan. NHI is an enabler of quality health and wellness for all. And our mission is to purchase quality healthcare services that are available and accessible to all through effective partnerships and sustainable investment in health. So we're talking about investment and not expenditure. Thank you very much.